Today we have something very interesting that we'll be bringing on the fore today, because a lot of people feel that every surgery should be the normal way where we have blood either being transfused or all of that. We have a lot to talk on this morning, and joining us on set to look at bloodless surgery. We have a consultant general surgeon, UCTH, and he is the president of Bloodless Medicine and Surgery Society. I have with us Dr. Nathaniel Usoro. Good morning, sir. So good to have you on the show.
Good morning, Joseph and Jesam. Good morning, viewers.
Thank you very much, sir, for joining us on the show. Let us quickly start with this concept of bloodless surgery. I'd love you to dissect it for us. Let me use your medical term. Let us get to know everything that we should know about bloodless surgery. What is it all about?
So bloodless surgery is the provision of quality surgical care to patients without the use of donor blood, what we call allogenic blood. And it has aims. The aims are to improve surgical outcomes and also to protect patients' rights. Now, it may seem like a new thing, but actually it is as old as the practice of surgery, because blood transfusion actually came in during the First World War, and there was surgery well before that in the previous centuries. So once blood transfusion came in through the World Wars I and II, it came into civilian practice and assumed that it was beneficial and safe. And all we did is ABO and RH. But recently, with evidence-based medicine, we found that actually blood transfusion harms. And not only that, the efficacy is in question. But it started with patients objecting to blood transfusion and an attempt to accommodate them. And then it was found that rather than dying off, they were actually doing better. So the World Health Organization is actually encouraging all clinicians to avoid blood transfusion. That is what they call patient blood management, which is now international.
You just said something here that blood transfusion harms. How? Because we have the impression that blood transfusion save lives. So
that is what we all thought until evidence-based medicine came in. And by 1988, the National Institutes of Health in the United States challenged medical scientists all over the world to prove the efficacy of blood transfusion. But you're asking about safety now. So I can make it easy to understand by giving you two major ways in which blood transfusion harms. One is that once you store blood, storage lesions develop. That is to say, it degrades. We cannot put blood in the freezer, but it's biological tissue, just like the meat that you might buy from the market. We put it in the freezer, right? We cannot do that for blood, because how would you even transfuse it afterwards? And it would lyse, it would destroy all the cells. So what we do is we put it in the fridge. So that's maybe between 2 and 8 degrees centigrade or Celsius. So it degrades immediately in two ways. One, it degrades in the physical properties, and then it degrades in the biochemical properties. So we say we're transfusing to improve tissue oxygenation. That's what we say as doctors. But the evidence shows that it does the opposite, because the red cells that carry the hemoglobin, that carry the oxygen, degrade, they transform, they become poorly shaped. So they cannot actually pass through the capillaries at the tissue level. So they cannot by any means supply the oxygen. Then because the supply of oxygen is an active process, so it requires various enzymes and things, ATP, nitric oxide, and so on. Those things degrade. Therefore, all we are doing is putting a colloid in the patient, and a dangerous colloid at that, which actually impairs tissue oxygenation. That's just one aspect. The other aspect is that blood transfusion is a biological therapy. It is a tissue transplant. Just like you take kidney from one person and put in another. Nobody does that with just ABO-RH compatibility. For kidney or most transplants, you would need to do what is known as HLA, that is human leukocyte antigen compatibility. Without that, you're certain that that tissue will be rejected. We don't do that for blood transfusion. And yet, the name HLA means human leukocyte antigen. So why do we fastidiously screen for it when we are moving a kidney from one person to the other, only to pour everything from the blood into someone else? So we don't do that because it will be too expensive. The blood transfusion will cost as much as a kidney transplant. But evidently it's not really scientific to have. So immunomodulation, there are immune problems that kill a lot of patients in the short term and in the long term.
Okay, doctor, before we lead you to telling us how the bloodless surgery works, let's get to know, because even up till yesterday, so to say, there are normal practices still ongoing. Now, in the case of severe anemia, how do you do it? Because I don't think just to save the life, we still have to do blood transfusion.
So right now, in the modern world of medicine, severe anemia is not treated with blood transfusion.
Okay.
The core ingredient of the treatment is iron. So if it is, if there's no emergency in it, oral iron can do it. It has what is called adjuncts. It's not just the iron. You need to add some things which people look down on, but scientifically it works. Vitamin C, vitamin B12, folic acid if there's no malignancy, and of course proteins or amino acids. Sometimes we can push the body with erythropoietin. Okay, but if it's urgent, like or very severe anemia, we give intravenous iron.
And it will boost the blood count.
Definitely.
Then how about diet? Like in cases where it's not like an emergency, like you said. So how can one's diet help in building the blood count too?
Right. So like I said, there has to be protein in that diet because part of hemoglobin is amino acids. There has to be all the iron, foods that contain iron, folic acid, those are vegetables. And you need to have vitamin C there. You know, fruits that contain vitamin C will do it. Meat will give you B12. You know, so that's how you can build with the diet. But you can also swallow the tablets. So we can rapidly boost within days. We can rapidly increase the hemoglobin in a way that blood transfusion does not. That is the key thing. And that is why intravenous iron is now referred to as a rational way of raising the hemoglobin, not by me, by the authorities, the hematologists at the top in the world.
Are there some myths around this bloodless surgery?
Yes, there are lots of myths.
Can you talk to us on that?
Okay, so for instance, some people would say, well, it's only in elective cases, those cases that you have a lot of time. No, it's for all cases, because it is known that blood transfusion, number one, is bad for all cases across board, whether emergencies, trauma cases, and so on and so forth. Number two, the techniques in bloodless surgery can be applied, whether emergency or elective. Number three, the outcomes are routinely better, whether elective or emergency. There are four major pillars into which all the techniques are built. Techniques that raise the hemoglobin, like you mentioned. Techniques that minimize minimize blood loss. They minimize blood loss. Then techniques that actually improve the tissue oxygenation, which blood transfusion reduces. And then techniques that help the body to cope with anemia. And they are all simple techniques that we can apply, emergencies or not. Another myth is that some patients need blood transfusion. That myth is blown. Nobody needs longer hospitalization or worse outcomes, which I said scientifically is proven in all circumstances. It used to be thought that open heart surgery, for instance, cannot be done without blood transfusion. But it's now routine. It's routine with various techniques. So it's a myth that blood transfusion benefits the patient. It's actually a myth. And I think gradually it's going out all over the world.
Yeah, because I was actually getting to that. If blood transfusion does more harm than good, why is it still practiced in many renowned hospitals? And it's even like a norm.
So it's still practiced because it takes many years to change things in medicine. Okay. We are very, very slow to embrace new things. In a way, sometimes it's an attempt to protect the patient. But we don't want to jump into a new thing that is not proven. But also, it has a negative effect in that we hang on to tradition a lot. For many years, you won't believe it, many years in medicine, the practice was actually to draw blood and throw it away. Up until the 19th century. That was it. That was bloodletting. That's, it was believed that you take out the disease by pulling out blood and throwing it away. So it took years to correct that. So right now, because we're in the information age, the information is actually going around. So if you go online now, you discover that bloodless medicine and surgery is not just a matter for patients who object to blood transfusion. It has to do with improving outcomes. But you may see it under the name of trans, because the World Health Organization is trying to get rid of that prejudice that it's only for patients who object to blood transfusion. It's actually good practice for all patients.
Okay, doctor, please tell us how the bloodless surgery works. Let's now get down to the main crux of it.
So, right from the moment we see our patient, our technique starts. Is it an emergency? Is it a cold case? Is the patient actively bleeding and all that? What is the hemoglobin? We can check it right within the clinic. So we know exactly, and we can start taking measures under those 4 pillars I told you. For instance, if a patient is actively bleeding, the WHO says take steps immediately to stop the hemorrhage. If it's like due to trauma, we can bandage, we can give tranexamic acid, very critical. They're encouraging everybody, all clinicians in the world, use tranexamic acid. It works. It's a simple medication which minimizes hemorrhage. Vitamin K works. In females who may be bleeding excessively from their period, the gynecologists have ways of stopping it altogether so as to build the blood and perhaps for surgery in future. So then we can, if we stop the hemorrhage, we can build up. We start immediately. If it's an emergency, we start immediately with intravenous iron, intravenous vitamin C, and other vitamins, and if necessary, erythropoietin. We have a protocol. So we use that protocol. So if we're going in for surgery, at surgery we take some further steps to minimize hemorrhage. Even positioning of the patient. If we're going to work, let's say, on the neck for a goiter, we're going to make sure the patient is head up, because if you put the patient head down, there will be terrible hemorrhage. If we're working on the other side, like maybe we're doing a hemorrhoidectomy, we do the opposite. Put head down. Those things can drastically reduce blood loss. So we can use, if we have diathermy, we should use it. It is ideal that we should have diathermy. Remember the tranexamic acid I mentioned, we also give it. Other medications to minimize hemorrhage. We are careful at surgery, we don't just keep going while the patient is bleeding. We stop the bleeding. We have ways of stopping it. We can use that diathermy, we use artery forceps. We have things that we put, we just put it on the bleeding and it stops. Those are topical agents, like Surgicel and so on. So our surgical technique and all that, we can actually collect the blood that is lost, if it's much, and give it back to the patient.
Isn't that some form of transfusion too?
No. For one, it's the patient's own blood, so the immune issues are not there. 2, we don't store it, so there's no storage lesion. So,
yeah, doctor, all these things you're saying, they kind of sound simple to listen to.
Absolutely.
But how realistic, how achievable are they in Nigeria, so people will have the ease that this is a bloodless surgery and I can go for it, so I don't need to be afraid that one thing might be available, the other won't be available?
So I'll give you a simple reason to understand that it's very achievable. It's not Nigeria, Calabar. Here we are in Calabar. We do these things routinely. in University of Calabar Teaching Hospital. It's a multidisciplinary practice, so it's not Dr. Usoro. It has to do with surgeons, anesthesiologists, hematologists, nurses, pharmacists. We have a group, Bloodless Medicine and Surgery group. So all kinds of people connected with the practice are there. There is not a single type of surgery that we do here that we don't do without blood transfusion. And so far, we have been blessed with zero mortality, zero. We haven't lost, like all those things you hear, oh, somebody had a fibroid and died. We've never experienced it in the bloodless group. So because our surgeons, the gynecologists and others, they take extra precautions. There are some steps they take, which other surgeons may not bother to take. They just say, oh, there's blood in the bank. But that blood, I have not exhausted all the problems of the blood. If somebody is bleeding and you transfuse, that patient actually bleeds more for very simple reasons. We have anticoagulants in the blood. And secondly, all the platelets are dead after 24 hours. Yeah, if you put blood in the bank, after 24 hours, there are zero platelets. So when you push all those things into the patient bleeds more, actually. And you don't get 5-6 units from one donor. You get it from 5-6 donors. So we put it in one patient. What happens is that is what we call disseminated intravascular coagulation. So patients actually bleed to death from transfusion. So, but we don't have all those problems with bloodless. We have patients recovered 3-4 days, they're out. Cesarean sections, routine. They are routinely done. Name any kind of surgery. We've had actually even patients from CRBC who have had bloodless surgery. So it doesn't have to do with religion or all that. Patient can say, I don't want blood transfusion, and the patient will be accommodated for whatever reason. Clinician too may want a better outcome and can decide to use those techniques. Prostatectomy, whatever. We've done all those things. Open reduction, internal fixation, hip replacement. Mastectomy is routine.
That's a huge advancement in the medical world. Now let us look at how to build your blood count. Let's look at that. Maybe the medical way and also the natural way.
Right. So like I said, the cornerstone of building the blood is iron. You have to remember that. And that iron ideally should be oral. The problem with oral is that one, it may take a bit more time and the absorption is not certain. So many authorities around the world advocate for intravenous. So intravenous, especially perioperatively, because issues of inflammation can impair absorption through the normal route. So iron is key. Then we add those things that I mentioned. Vitamin C is key. Vitamin B12, folic acid if there's no malignancy. In malignancies, we actually give antifolics. So we have other medication we can use to escape that. So as I said, you need proteins. They are simple things. There's nothing wonderful or magical, but they work. That's the key thing. So once we wrap it around our brain that the blood transfusion is actually harmful and the efficacy is in question, then we now go into the area that is proven scientifically. And you just need to key in. You can Google it, Google either bloodless surgery or iron therapy. So it's not a fringe kind of thing. It is now applied across board in cancer cases, all kinds of cases.
Okay. Now, bloodless surgery, like you rightly stated, has been on for as long as surgery in the medical world. How can we now eradicate the stigma that comes with people who choose to do bloodless surgery? Since this is there in the medical world, but some people choose to accept this form of treatment and others decide not to. How can we eradicate that stigma that comes with it?
So it's through education. And what you're doing now is very important. You're trying to find out things and you're sharing that information with your audience. So that educates a lot of people. For instance, I mentioned CRBC staff that had bloodless surgery. It's because she heard this kind of thing and said, I'm about to have surgery and I want it bloodless. The doctors, for instance, in our center, UCTH, I don't think there's any doctor there that has not heard of bloodless surgery or perhaps taken part in bloodless surgery because of education. We hold seminars, we hold meetings, we present, and they actually become part of the practice. So the World Health Organization is promoting this worldwide. We have societies, professional societies around the world. We have the Bloodless Medicine and Surgery Society, it's international. We have Society for Advancement of Blood Management, it's international, based in the US. Various regions. I've just been invited to speak at the Asian Society for Patient Blood Management. So they formed something there. The Chinese Blood Management Society. That's to help the professionals to get away from blood transfusion and embrace principles of bloodless. So as that education, I then books, journal, now have textbooks, which did not exist maybe 10 years ago. Textbooks of bloodless surgery, textbooks of patient blood management, and so on and so forth.
Okay. Doctor, let's get to your message for cross-rivarians and residents on the bloodless surgery.
So my message is that this is actually the evidence-based thing, is the way to go in order to have a better outcome, faster recovery. It's cheaper because a unit of blood now is maybe 10 to 15,000 naira, whereas all those interventions I mentioned may not cost up to 5,000 naira, depending on the situation. So it's safer because you avoid, I didn't even talk about issues of infection. There are lots of blood-borne infection. Now we're talking about COVID-19. We know that it is there in the blood. I mean, there's no way anybody can run away from that. And lots of other things. How many do we test for? Just 4. HIV, hepatitis B, C, and syphilis. So it's a safer, more rational way to go. It's possible to discuss with your doctor if you're a patient. I would like to have bloodless surgery. The doctor doesn't have to know everything that I'm saying. He can actually call in the bloodless surgery team and say, okay, this patient wants bloodless surgery. Can you guide us or work with us? We do that without charge. We don't charge any money for that. So it's part of our social responsibility. For our clinicians, you know, in medicine we have to keep studying, all of us, no matter what level you are. So all our clinicians need to do is to examine the subject, get rid of the prejudices, try it, and see how often are you going to present mortality review to go and talk about a patient you lost. It's dramatic. You might not even have any patient you lost, except maybe unavoidably, like somebody has advanced cancer. Okay, but you can have hemoglobin. We've had hemoglobin of 1.3 in our center that we save the patient by bloodless. You cannot. If anybody has saved the patient with that hemoglobin by transfusion, I'll be happy to learn from that person. But it is almost impossible because you're going to do massive blood transfusion, which comes with terrible dangers and mortality. But so clinicians can study the subject, try it, call in. Don't be shy about calling in people to say, okay, could you help us with this? And after a while, you develop the confidence. You can start with patients who object to blood transfusion. That's easy because they're already objecting, they signed. You start with them, see the outcome, and you can transfer the benefits to every other patient, you know, because patients come to get well. They don't come for blood transfusion. They come because they are ill, and if you're able to get them well and go home in time without transfusion, they're happy. So you can transfer that confidence and those benefits to other patients.
Thank you.
Dr. Nathaniel Usoro, Consultant General Surgeon, UCTH, and President, Bloodless Medicine and Surgery Society. Many thanks for your time on the show this morning.
Thank you very much.
And we hope to have you subsequently to discuss further on other issues.
Come back anytime. Thank you.
It's a Good Morning Crossover, the Wednesday edition. Great talk there with Dr. Usoro, and I'm sure it's a push from the norm, what we call the paradigm shift.